Uh, in the last session, we discussed same about the wound management, right? And in that session, we exclusively saw about the pressure ulcers. And today in this session, we are going to see how to focus and manage, malignant wounds. That is what, the major topic about today's session. And it's really, good to talk about this essential topic, about malignant wound because it's always overlooked, right? People think that there is a wound, we have to do the dressing. And here in this kind of wound, when we talk about palliative care, our total focus is different. Like we are not only doing a dressing, we are comforting the patient, we are providing a symptom relief to the patient. And we also, think about dignity of the patient when we do the dressing, how to expose, how to do, and, all these things. Because the wound in palliative care is not that easy. It is very unique and it has got a lot of challenges. And you need to have a different approach altogether to manage these things, especially to look into the quality of life of the patient. That is what we are going to see. In this session, I'll talk about overall what is wound basically, and what is palliative care wound, what are all the assessment tools we will use, especially when we talk about malignant wounds. So what are all the assessment tools we will use, how to manage this. This is what we are going to see. And as we all studied in our nursing, right? Here the wound is nothing but if there is any cut or any accident, any damage to the epithelial tissue or surface, we call that one as a wound. That is what we have been studied. And we also, we have been taught about if there is a wound, there is always a healing process, right? Any surgery, any accident, whatever it may be, there is a time period. Okay, this day 1 to day 14, the wound will heal, the patient become all right. But what will happen in the palliative care wounds, right? So when you look into the prevalence, overall prevalence about the wound, there is about chronic wound and acute wounds. And most of the times, what we see here is we always take care of acute wounds, and we are very good in taking care of acute wounds. But when we talk about chronic wounds, most of us doesn't know how to handle chronic wounds. If you look into the prevalence rate, the acute wounds are more, that is 10.5 per thousand population. Chronic wounds are less, but these less chronic wounds create a lot of complications. That is what we are going to see. In this session, I'm not going to talk about acute wounds. I'm going to focus more and more on chronic wounds, how to take care of these wounds. When we talk about palliative care, the wounds are very complex. As I said earlier, the wounds are very complex, which is not going to heal at all. The wound will be there as it is. And the major problem here it will deteriorate further. It will not, heal. It will not be as it is. It will deteriorate further. And it needs, a lot of attention to the palliative care patient and circles of care. So this is what, it's not only affect the patient, right? In the palliative care, the patient will be having wound. Who will do the dressing? And every caregiver is not a trained caregiver, right? And you have to do dressing for the caregiver, dressing for the patient, the untrained people. So a lot of effect will be there on the families also. So that is what they said. It is very dynamic, very complex. And it is involving lot of complex between the patient as well as family around the circle. So in general, we saw about what are all the types of wound, okay, acute and chronic. When we talk about the wounds in palliative care, these are all the types. So as we discussed in the last session on Friday, we spoke more about pressure ulcers. That is, majority of palliative care patients, because of their immobility, because of their impaired activity, because of their poor sensory perception, they get pressure ulcers. Apart from this, there are majority of the wound is malignant wounds. The malignant wounds are like the patients with the cancer and everybody, they have a lot of malignant wound, and there is a ulcerative wounds. So this is what the overall classification. says. So last session we saw about the pressure ulcer, and this session we are going to see about the malignant wounds. And you all know as a nurses how to take care of ulcerative wounds like diabetic wound, like any other common ulcers. You know how to take care. Okay. So here in this, our focus is there could be this can't be treatable. These wounds are not treatable, but we have to take care of this wound. How to provide care to this wound? That is what the challenge. This is what the real life experience people says. This is what we heard from the patient as well as the caregiver. The caregiver saying that the patient first, when we asked the patient said that every day the nurses are coming and doing the dressing, but still there is a drainage, but still there is a foul smell. And I'm so embarrassed if I see my wound on the breast or the buccal mucosa or whatever it may be. I feel bad to go outside. I feel very embarrassed. My family is not coming to me. One patient said, my grandchildren is not kissing me. Nobody is around me. I'm always at one corner. Why I am being here? I don't want to be, here. And this wound is, very bad. This is what the patient said. What the caregiver is saying. Actually, I love my mother. I love my father. I love my husband. I love my parents, but I don't know how to take care of this wound. I don't know to help. I feel most of the time so helpless because the reason is when I go next to the wound, I feel like nauseated. If I tolerate and do the dressing, I can't take food for next 2 days. This is what the family member said. This is how every day we are facing the scenario in the hospital setting with the chronic wound. Now, here the question is how we are going to manage this situation as a healthcare professional. What do you do as a nurse? You tell. How do you do? Anybody?
Participants, please answer, unmute yourself, or you can put it in.
Yeah, because it's a nice session, wound management. Nurses already doing lot of dressing. If you talk more and more, we can discuss a lot. Otherwise, it would be, monotonous. Whatever I know, whatever we practice, I used to say. When we talk, it will be, exchange of knowledge between both of us. How do you manage if the patient says like this, caregiver says like this? How do you manage as a nurses? Yes, somebody?
According to patient condition.
Yeah, you will understand the patient condition. Then this is the condition now. The patient is having malignant wound. Somebody has to do dressing, but the caregiver is so helpless. How do you manage?
First, we have to clean the patient side before doing the dressing, before doing the take care of patient.
Excellent, excellent.
And
Very
we
good.
have to explain the patient what we are doing procedure.
Mm.
Before
Very
doing
good.
procedure, we have to explain the patient, and we have to take care of the patient. Very aseptic technique.
Mm. Very good, Dan Maya. Thanks for your contribution. Excellent.
Okay, thank you, ma'am.
She said about because the caregiver said feel nauseated, right? The wound is smelling badly. So the right point she said, give bath before you do the dressing, right? That is a very valid point. Thank you for that. Let's see how we are going to manage. Yes. This is the real scenario because the problem why this malignant wounds are important because the wound is not going to heal. The complexities are more. Why it's so complex? This is complex because there are 4 factors. The first factor is patient. Okay, the patient, patient related factor. Other is wound related factor. Other one is healthcare professionals, our problem. The last one is resource related factors. These are all the problem. What are all the patient related factor? That is because where the wound is located, that itself a problem. Imagine if the patient is 2 patients. Imagine 2 patients. One patient is having wound at the breast. One patient is having wound at buccal mucosa. Which is easy to manage? Tell me. Which is easy to manage? The wound at buccal mucosa or wound at breast? Which is easy to manage? Chat box. Some people are all at work. If you are at work, just put it in the chat box. I gave two options. Breast wound is easy to manage or buccal mucosa is breast wound. Yes. Next.
Breast wound. Breast wound.
Breast wound. Okay. Most of them is going with the breast wound. Yes. Excellent. Breast wound is easy to manage. Why is it easy to manage? Any idea? Why is it easy to manage? Any idea? Why the breast wound is easy to manage?
It should not be pressurized point because it is in front of patient chest, no?
Okay, it's not in the pressurized point. That's okay. Then buccal mucosa also, it's not in the pressurized point. It's not under bony prominence. Don't think your pressure ulcer is over. Don't think about pressure ulcer. Think about malignant wound, cancer wound. Why the breast wound is easy, buccal mucosa wound is difficult? Yes, easily dress. Yeah, easy to access, excellent. Easy to dress, excellent. Accessible is easy, easy to dress. Yes, yes. Somebody? Okay. Let me talk more about it. Okay. The thing is, why I said the location. Imagine the patient with the breast wound is easy to locate. Yes, you can go next to the patient, easy to locate. Sometimes patient itself, they'll do the dressing or it's for caregiver also, it would be easy. And there is no any foreign bodies will be involved with the breast. Okay. But if you look into the buccal mucosa, the problem here is the buccal mucosa is the area where the patient want to eat, right? The work will be more. The patient will eat, the patient will drink, the patient will talk. The work will be more in the buccal mucosa. And already the wound is fungated and ulcerated wound, the malignant wounds. And on top of that, if the patient eat, the patient drink, what happen? The anaerobic bacteria will grow more. So the wound will further deteriorate, and the cleaning and making the patient to understand it will be very difficult. That is the reason the patient related factor, the pathology where the wound is located, and how difficult to access, how difficult to do the dressing, how easy to the prognosis or the deterioration will occur. And top of that, the next thing what I have been saying that the comorbidities, whether the patient, if the patient is having multiple comorbidities, again that is a problem. Is the patient is allergic to any medications? If the patient, tolerating the pain, the patient doesn't tolerate the pain or the patient doesn't cooperate, you can't do any dressing, you can't do any management. These are all the patient related factor. If the patient doesn't cooperate, it will be very difficult for us, ensure the wound management, right? So the patient, the wound will not heal, the wound will become more and more chronic, the wound will further deteriorate, they will come to palliative care. So this is patient related factor. What about wound related factor? Wound related factor, as I say, where the wound is located, right? Whether the size of the wound, the shape of the wound, and the wound is having any slough, the wound is having any further deterioration, how the wound bed is looking. So all these things are wound related factor. Sometimes the wound itself a complicated wound, right? So it will be very difficult to heal the wound, manage the wound. So that is one more complex why the wound is not healing. The third thing is healthcare professionals that why we are a complex to patients, because see there are two things within us. Okay, how much we are knowledgeable in managing the wounds. Second things, how much we are skillful in handling the wound. These two things are very important. So when you talk about the manage knowledge, so most of the nurses having knowledge about managing the acute wound. If it is any burns wound, any fall, any surgical wound, or any other wound, it's easy. We know, okay, we know this is the management. We have to wash with betadine, we have to do the proper dressing. So we will manage. But what happened to the chronic wounds? You don't know what happened to the ulcerated wound, what happened to the gangrenes. It's very difficult. We don't have knowledge, and you don't know how to do those dressings, right? If you don't have proper knowledge, proper dressing, so what happens? The patient, that becomes more and more. They'll do the wrong diagnosis, wrong dressing. The healing will not occur. That becomes complex. The last thing is the resource factor. Resource factor is, imagine the patient is living in very remote areas. The patient is living in very remote areas. The patient, can't able to access to any hospice or hospital or palliative care settings. So first time when they come for checkup, they will come for wound dressing and everything. And second time, the patient is symptomatically better and they have to come for dressing. They don't turn up. They find difficult. Oh, we'll go for only for the dressing, right? They don't do that. So that is also one more reason, like they don't, come for a dressing. Okay, the resource availability, that is a healthcare system overall. The Indian setting, the healthcare system is having a shortfall on that. So these are all four major factors. One is the patient itself, the wound itself, and we are as a doctor and nurses, our problem, and the resource facilities. These four factors is joining in one or the other factors, joining and make the wound more and more complicated. Once the wound more and more complicated, and it will not heal, and again further process, and they will do. And if the management is good, if the patient, satisfied, wound is healing, they can manage as it is the regular dressing and everything. If it is not there, the cycle will continue again. So that is why the palliative care, the wound management, especially the fungated wound management, are very, very important. Understand my point? Next, now you know. Now I said the wounds are so complex. There are a lot of factors, involving the wound will not heal. Now, what is your goal? But still you have to do something, right, as a nurses and doctors. So your goal is here is providing comfort and focus on the symptom control. Here you can't do much on the wound. You have to provide comfort and focus on symptom management and inform the family. Okay, what is the best management? Because whenever the patient comes to clinic, they say that I this wound is troubling me so much. I want this wound to heal. Okay, so understand what you can do better and ask the patient what is their concern and take an informed consent from the patient. And till last moment, the quality of life is very important. Till the end of life care, the quality of life is very important. That is what we have been working for this. Okay, though the wound is not healing, the wound is there, but the patient will live for next 3 months, 4 months. You just can't leave the patient like that, because further they develop infection, it will end up with sepsis, septicemia, and patient will die. That should not happen. That is so painful, so costly. It will burden the patient a lot. So that's why you have to, your goals of care will change. So provide comfort and focus on the symptom. Inform to the family members, ask the patient consent, and make sure you're providing a quality of life till the final stages. That is very important. And now here, where to start? Now you decided, yeah, I'm going to, manage the wound. How are you going to manage the wound? Where you are going to start? Okay. Whenever you start with the past history. Okay. When the wound started. Okay, what happened? Have you all finished pain assessment, pain management class? Have you all completed? Anybody? Have you all completed pain session? Yes. Somebody is talking. Yes, yes. Anisha, can you mute yourself? Yes. Thanks for your response. Yes, you have finished your pain assessment. In pain assessment, they taught about how to ask pain history, the mnemonic. What is that mnemonic? If the patient is complains of pain, how will you ask the patient? How will you take the history? Anybody? I'm saying I have pain. What will you ask as a nurses? If you are on duty, put it in the chat box. How will you take pain history? Yes, very good. Facial expressions, excellent. Beauty, Kumari. Then body language, very good. These are all non-verbal. Verbally, how do you do? Wong Baker scale. Yes, that is a scales. Excellent. You use a scale. You want to collect history, pain. How do you do? Excellent, Meenakshi Dhyani. Excellent. Okay, PQRST, right? You will use the PQRST format. Okay. So same thing is applicable even in the wound also. When you talk the history, use the PQRST. Now it is prefix O also, onset. Okay, OPQRST. Okay, not only PQRST, it's OPQRST. Okay. So that you have to use. So ask the patient when the wound started. Is that any provoking factor or palliating factor for the wound? Q, the quality of the wound. Is that any all other PQRST will do. The next thing is look at the wound bed. The wound is there. Look at the bed. When you see the wound bed, it will give you an idea. Okay, either the wound will heal or not heal. When you look at the wound bed, what do you see? If the wound is healthy, how the wound bed will be? Tell me. The wound is healthy. Yes, onset, quality, radiation. Very good, Nisha. If the wound is healthy, how the wound bed will be? Anybody? You see, there is, fresh wound, the cut or accident or any cesarean section, surgery, anything. You are looking at the wound bed because that all is going to heal. How the wound bed will be? Wound bed is nothing but wound area. How it would be? The entire wound. Anyone? Come on, speak. Unless you speak, I will not move to the next slide. How the wound bed should be? Anybody? The wound will be clean. Yes, no pus. Excellent. Choke. And any incisions or open wound should be checked. Air weight. Yeah, very good. Red area. Excellent, Meenakshi. Red area. Yes. That is what you have to see in the wound bed. If it is the wound is going to heal, the wound bed will be, red, pinkish red color. Okay. It's a healthy wound. So, the wound is going to heal. But here, these people like ulcer wound and all those things, what happened? Thank you, Bindu. Now, what happened? The wound bed won't be pinkish red. It would be very pale, pus, infection, slough will be there, and exudates will be there. All these things would be there. That's what I have told you to check the wound bed. The PQRST, past history, OPQRST. Then you have to check the wound bed. The third is after checking everything, now your wound is there, you check. Now you have to decide what is the evidence-based practice. So the wound is so and so, I have to do proper practice, I have to do proper dressing. Then you have to select. Once you select the dressing, what kind of dressing you are taking, look at the risk. Okay. It means whatever you do, it has to help the patient. So you should see, it should not complicate the patient, trouble the patient, harm the patient. So you need to look at that risk. Clear now how to start. Now the wound is not healing. You have to do something. So you start with past history, check the wound bed, do select the evidence-based dressing, what is the current guideline, and look at the risk. Okay, I selected this, whether it will be beneficial to the patient or it will be harming the patient. That you have to do. Clear? No. So whenever you start with the dressing, your first thing is wound assessment. Okay, I told you in the last class also. So it will give an idea. First, you nurses should have good observational skill. You should examine the wound. Then you do send for the investigation if the wound is infected. So it's in palliative care. The wound assessment is not only about the wound. It is about the patient. So you need to have a structured assessment. So it will help you, to get a proper informed decisions. Okay, the decision will help to relieve the symptoms, dignity, and improve the quality of life. And look at the wound extent, and look at the wound severity, and look at the wound burden. If you do the proper assessment, you will come to know how extent the wound is, how severe the wound is, how much the burden the patient and family caregiver are going through because of the wound. All this idea you will be getting. So your aim of doing wound assessment is identify the cause, reason for the wound, why the patient is having wound. Is there any other factors are associated? We read lot of factors, right? The factors about the patient, the factors about the healthcare professional, the factors about the wound itself, the factors about the resource facility. All these things you have to see. And once you come to know the cause and correct the cause, correct the correctable and appropriate treatment options, and control the wound related symptoms. What are all the wound related symptoms you need to control, and prevent any skin deterioration, and identify patient expectation, what the patient want. All the ideas you will get if you do the structured wound assessment management. I'll tell you how to do. So you need to provide, sometimes the patient would be worried, the patient would be distressed. All these things also, you will come to know. And you also come to know either the patient himself or herself can do the dressing, or the patient needs some kind of support to do the dressing. So to do everything, you need to have some parameters. Okay, this is what that is the aim, how we are going to do. Now, these are all the parameters. So first thing, identify the cause. Why the patient has got wound? It is because of cancer, or it is because of fall, or it is because of surgery, or it is because of any infection. So identify the cause. Look at the location, because that is what I have asked the question at the beginning. Either the wound in the breast is easy or buccal mucosa easy. You all answered very nicely. Breast is easy because the location of the wound, it is easy accessible. There won't be any contamination. Okay, easily you can do the dressing, right? So location of the wound and the stage of the wound, right? Either the patient is in the initial stage or the patient is in unstageable, or you can also see whether the wound will heal, phase of the healing, okay, by looking at the bed, right? Whether it is pinkish red in color or it is, very complicated in healing. The size, whether it is small wound or it is complicated. If you see cancer wounds, you never get any small wounds. That is very less percentage. Always you get a huge wounds. Okay, you can sometimes I have seen one patient started a wound from the mediastinum, breast wound to the spinal cord. Okay, the entire side of the breast, complete breast front and back, there was a wound, right? And is there any undermining, tunneling in the wound and condition of the wound bed? Is there any exudates? You see, all these fungated wound will be always shiny. Okay, there will be a presence of mild exudates, right? And look at the peri-wound skin. Always, we have been studying in from our nursing. You have to see the edges of the wound. If the wound edges are healthy, and it shows no, the wound will heal. But this kind of wound, it doesn't heal, but it doesn't deteriorate also. So we need to see, and is there the patient is having pain, which is very, very, very important. In case if the patient is having pain, you can't go with the management. Your first goal is to reduce the pain in the wound. Okay, so these are all the parameters for the wound assessment. And once you start, you need to have some scales, how to do wound assessment. This is very good scale, time scale. Okay, this is called time scale. You do time assessment and you do the reassessment, okay, which is very important. So when you do that, take the time scale. The scale will give you the idea of the tissue, how the wound tissue is there any inflammation or infection, how the moisture balance, how the edges, epithelial edges of the wound. So it will give the entire idea. How to use the time scale, I'll teach you. For one of my patient, I use the time scale. I will show that you will get an idea. So this is also one more scale, and this is about TOVA scale. TOVA scale is triangle of wound assessment. This exclusively about only the wound, okay, the wound bed, surrounding skin, and the edge. Okay, all these things. How is the tissue type? How is the exudate? Is there any skin? The wound edge skins are thick or thin or dehydrated. Is there any undermining? Is there any, maceration? All these things, you will get an idea by using the triangle wound assessment, that is a TOVA assessment. But very common is the time assessment is very good. Last class, I have been taught about the scale wounds, right? The end of life scale wounds. There you will have 5 P's. I told you prevention, prescription, preservation, palliative, and this one. So this is for this scale wounds, even with the malignant patient. They will have malignant wound, and towards the end of life, they will develop scale wounds, Kennedy ulcers, right? I told. And in 2018, they, named this as a scale ulcers because when the patient in end of life care, there would be a failure of hemostatic mechanism. Okay, so the patient developed this kind of pressure ulcer which can't be prevented. We discussed this in very detail in the last session. So I'll move on to the malignant fungating wounds. Now exactly we came into the point like how we are going to handle malignant fungating wound. Very common wound among cancer patients. 95% of the cancer patients, they will have a malignant fungating wound because these wounds infiltrate and proliferate the malignant cells and the skins, So it not only, affect the blood, it also affect the lymph vessels. So the entire body it used to spread. Okay, that is why it is very complicated. You could see 5% of advanced cancer patients will have malignant wound, metastatic wound 10%, and life expectancy is very less. Within 6 to 12 months the patient would die. How to manage this? Why it is so complicated? The malignant wounds are highly complicated because it always got a disease, right? Its underlying disease is a cancer. So it is very progressive in nature. It will continuously affect the microenvironment and microbial growth. So that is the problem, underlying factors. And metabolites. Okay. So anaerobic bacteria will grow in the malignant wounds. So that is what is the that caregiver said, no, I feel nauseated because of this anaerobic bacteria. It's very difficult. I have seen many of our nurses after doing the dressing, sometimes they find very difficult to eat their food. So anaerobic bacteria leads to increase the exudates, pain, and odor. And this is very dynamic wound. Tissues are involved, vascularization, affected, and all these things are complex. That is why malignant fungating wounds are highly complicated because of the cause, disease, because of the microbial environment, because of the wound character. All these things makes the wound complicated. Now you have to tell me, okay, this is the case. Okay, see the case. This lady is having invasive carcinoma, left breast, 45 years lady only. And she went to chemotherapy, radiotherapy, everything. And she has got 3 sons, elder son, having one more disease. She herself, the patient, and an elder son also is a chronic patient. Second son, breadwinner. Third son is studying, but he is the primary caregiver. Others can't take. When she came to the hospital, she came with the complaints of dyspnea because of the huge wound on her chest, fever, chills. She got infection, hoarseness, dysphagia, lymphedema in the left hand. She has got disturbed sleep. And she said there is a pain in the wound. Okay, when we evaluated, this is more both nociceptive and neuropathic pain, which is also radiating to the face, neck, and the shoulder. The wound is very much ulcerated, fungated, granulated. The patient is having pain, malodor, exudates, and bleeding. And she is bed bound most of the time. Okay, she can't do much of their work. How will you manage? What is your goals of care? Tell me now, put it in the chat box. How do you, as a nurse, how do you handle Siddhamma? Tell me. How do you handle Siddhamma? Anybody? Open your videos now. I can see, I can ask questions. Priya Chaudhary. Priya Chaudhary, can you unmute and tell? First, we will focus on pain management. Excellent, excellent, Bhutia. Good. Priya Chaudhary, are you there? Yes. Tell me. Anybody? We will focus on pain. Very good. Then anything else? What about dressing? How do you manage? Priya Chaudhary, are you not there? Nobody is answering. See, every day you are doing dressing. Now this patient with a lot of problem. As a nurse, first one is very good. She will manage the pain. Other people, only pain is to be handled. Sakshi Sharma, nutrition, very good, Bindu. Sakshi Sharma, are you there? Mamta, yes. Health education, yes. Hydration, very good, important points. Then dressing, yes. Mamta Joshi, thank you. So think about selecting a good dressing. Excellent, excellent, excellent. Now, let's see. Here, the question is not about getting cured. Siddhamma doesn't want to cure, but how she will live with the wound. Okay, I will show the wound now. So your approach here is the wound assessment. Start with wound assessment, do the decision making, and do the care plan. When you do the wound assessment, you have to see the wound, how the wound is, the size, location, infection, and all those things, and how will you, do other assessments like pain. Somebody said no pain, malodor, and whole person assessment. When it comes to decision making, you have to inform them, patients, what is the goals of care, whether the wound is going to heal or not, how the patient will affect psychologically, how to handle the patient as well as caregiver. That is the decision making. Third thing, the care planning. Okay, when you talk about care planning, and either the patient is having pain, the surrounding tissue, how is there any erythema developed, or the patient is malodor is there, or maggots are there, all these things have to be before you start with your dressing or assessment, you should have a clear-cut plan on what are you going to do with the wound. So this is what Siddhamma has got wound. Okay, it's not only one wound. You could see here the huge wound, and there is a multiple wound. There was also a wound on the subclavian region. Okay, just under the subclavian, she has got a wound. Yes, they said position change, inspect for wound type. Excellent, excellent. Okay, this is what the wound the Siddhamma has got. So what I have done with this wound is just started with the basic assessment. This is basic assessment. What is the size of the wound, site of the wound, either the exudate, it's little shiny exudate, it's mild exudates are there with the order, and edges are undermining, you could see, and red granulation is there, and necrotic tissue and slough. Okay, everything is there in the Siddhamma's wound. This is the basic assessment. So this gives an idea. When you check the size, you have to check the length, breadth, and the width. When you check width, take a swab. But put in that and measure it in the scale or inch tape, and you can write it. So this is what time assessment tool. I was teaching about time. No, this is what time assessment tool. So the first column says about patient profile, the basic profile. Siddhamma, she has got an ulcerated wound. And the second right side is showing the wound score, how much the patient is having wound. The time score, the tissue, more than 50% of the tissue is necrotized. So I rated 2. And the first one, other one is inflammation. I is inflammation, inflammation present. M is exudates, there is mild exudate. E is absence of dermis and epidermis. And what is the general condition of the patient? Okay, so the patient is 45 years, she is well built, and the mental status, she can able to understand everything, that is good. She is self-sufficient. Yes, because of breast wound, she has to manage herself. She is very confident, and there is no other predisposing factors. So I scored 1. The general score for the wound is 1 because the self-sufficiency, sometimes the nurses will come and do the dressing and all those things. And the wound, because it's most of the time necrotized, 2 inflammation present. Yes, 1 mild exudates are there, dermis and epidermis is not there too. So the total wound score is 6. The general condition is 1. The total score is 7A. In time scale, if any scores 7 or more than 7, it indicates the wound is not going to heal. That is what the scale says. The wound is not going to heal. So here it indicated Siddhamma's wound is not going to heal. So what am I going to do? So here the plan is twice a day dressing with the metronidazole, reduce the pain, and control the exudates. So the major problem here is severe exudates reduce. As somebody said very nicely, reduce the pain and control the exudates because it's, there is a drainage, and provide comfort and quality of life of patient. This is what my goals of care and care plan. So you have to plan like this for every cases. Understood? Now, I said what is wound, what are all the classification in palliative care and the assessment, time scale and everything. How I am going to manage. This is what the principles of management. So the first one is symptom management, take away all the symptom, provide holistic care to the patient. And the last one is empower the caregiver. See, when the patients are with us, we will be managing everything. But the patient is not with us, we have to empower the caregiver. The physical problems are this. The patient will have pain, malodor, infection, bleeding, exudates, and maggots. So how do you handle pain, right? So the pain is 2 types. Some people will have superficial pain. Some people will have deep pain. But the pain normally itself very painful. Imagine the pain with the wound and everything, it would be terrible, right? So that the pain, no, if it is superficial pain, you can apply lignocaine jelly, you can apply iniopium, citalopramide, and sublingual ketamine. But in case of deep pain, you have to go with the systemic analgesics 30 minutes before the dressing you have to do. Okay, then the patient will be settled then you can do in case you are planning the dressing at 1:30, give the dose at 1 o'clock, 1 PT dose, the patient would be all right. So this is how you have to manage pain. Then how to control maladar. Maladar will be controlled, as somebody said very correctly. Before dressing, do the bath to the patient. So the overall dirt will go, then you can do the proper dressing, sterile dressing to the patient. So daily cleaning and dressing is important. Here I mentioned daily cleaning, but in the hospice, we will do twice a day dressing, compulsory. And if there is any exudates or bleeding, change the dressing frequently and start the antibiotics, which is very important for the malodor. Now, so what do we do? There is something called metronidazole. Metronidazole is very much helpful. So you have tablet metronidazole. You take the 200 mg tablet, crush nicely, make it powder, mix it with Vaseline or liquid paraffin and apply it into the gauze. You could see it in the picture. In the box, there is a metronidazole powder. Here is the Vaseline. The nurse mixed the metronidazole and Vaseline. It became a pink cream. And you see how the nurse is arranging it in a tray. There is a rectangle tray. The gauze piece is cut accordingly, and she is applying the metronidazole paste in all the gauze pieces and arranging in the tray nicely. And that keep one or forces on top of that, send it for autoclave. Once it goes and come back from autoclave, this is how that tray looks. Okay, this is how the tray looks. And this will be used to reduce the maladar in the wound. Okay, this is what, you have to do. So another one, okay, so this is to continue that. So that is for locally. That is for locally you do the maladar and all these things. And when you see that if the maladar doesn't go, you can start the metronidazole tablets systematically. This is what the ladder, okay. As you have ladder for WHO pain ladder, for maladar also there is a ladder. So this is called sniff ladder, SNIFF, sniff ladder. So the smell, nil, faint, foul, and forbidding. Okay, this is what sniff ladder. And how to, this is the evidence-based study, the sniff ladder. This study is a retrospective study of 10 years of a research they have conducted in CMC Vellore, okay, in the palliative care department, and they submitted this paper, and this is how the study has come up. So this study is helping us to understand better how much metronidazole. If the patient is having metronidazole, start oral metronidazole 400 mg and 3 times a day, and continue for 200 mg, and again continue for 7 days and 200 mg, and repeat. Okay, for total metronidazole. This is so you could see the impact. The first thing, if there is very only smell, there is a microenvironment. Then if there is a faint smell, there will be a, the bacterial involvement. If it is foul smell, you could see, stigma, nobody will be there. And, if it is forbidding, you could see, the maggots, death, and everything will be there. This is how it is assessed. Clear? This is what called sniff ladder. So this is exclusively about metronidazole. In case the metronidazole, after using metronidazole locally, metronidazole systematically, still if the patient is having foul smell, the other type of dressing is charcoal dressing. Okay. So any wound, you can use charcoal dressing. So how to do charcoal dressing? Take a charcoal and crush it nicely. You can see how the nurses are crushing and swift it. And when you swift, you will get a fine powder. Put that, she dried it nicely in the sunlight. She will put that fine powder. You see in the top, there is a steel box. They will put it in the steel container and send that container for autoclaving. Once it goes and come from the autoclaving, that is called activated charcoal powder. This is now sterile powder. Now you can't take that sterile powder and sprinkle on this wound. Okay, that would be more painful. What you have to do, take that powder, put it on the Vaseline gauze, mix it nicely, make it as a black gauze, then apply it on the wound. So what happened? So it gives, take away all the foul smell. If you put directly on the wound, the patient will complain on you. I came, with the pink wound, pink cheek. you made it black, something fishy is happening. So they will question you very badly. So this is how you have to do. The next thing is about bleeding. Okay. Now we saw about how to handle pain, how to handle maladar. Now it's bleeding. When we talk about bleeding, okay, if in case if bleeding happens, okay. If there is no bleeding, if there is, no bleeding, your goal is to prevent bleeding. Whenever you do the dressing, make sure because of your procedure or whenever you approach patient, the patient should not bleed. How will you prevent? There is a wound. There is a wound. So if the wound is there, when you remove the dressing, wet the dressing nicely with the normal saline and leave it for 3 to 5 minutes. Then you remove the dressing. When you remove like that, one, you are reducing the pain. Second thing, you are reducing the bleeding also. So that's how you can prevent the bleeding. The second thing, in case if the patient starts to bleed, your first thing is put the turmeric powder. Okay, turmeric powder is the best for mild bleeding and apply first, prevent and apply local pressure. Third, only turmeric powder. Give a tight pressure for 15 minutes. The bleeding will stop. In case if it doesn't stop, it still bleeds, you can start with the turmeric powder. Turmeric powder also same like the way I told about charcoal. Take a gauze paste, the metronidazole Vaseline gauze is there. No, take that, put a turmeric powder, make it like a yellow gauze and apply. So the bleeding will stop. And if that doesn't help, if the bleeding is more, you can use a crawlfeed powder. You can use adrenaline 1:10,000 solution. Hydroclot will be very nice. The drops you can use. And the systemic ethamsulate and Trenexa. Trenexa you can apply locally. Cut a ampule, put it in the bowl and put a gauze piece and apply directly. Otherwise, directly you can pour Trenexa over the wound or you can give in a IV injection also. That also would be helpful. If the bleeding is more and more, the last option is palliative radiotherapy. Clear? This is how you have to manage bleeding. Infection, the only thing what you have to do, daily dressing with metronidazole. And whenever it's soak, do the dressing again. Okay, don't, stick with the timing and all those things. This would be helpful to do the daily dressing. Remember one thing in palliative care, very importantly, what you should not do more than what you are doing. You should not use betadine. You should not use hydrogen peroxide and you should never cut the slough. Okay, these things you should never do. Whatever the points I said before, if you don't follow, the patient will come to you like this, ended up because already it is a fungated wound, anaerobic bacteria. So the maggots will catch fast. Okay, so they will end up coming with the maggots. So here your option is turpentine and mercurochrome 2 to 4%. Very commonly we use turpentine. And take the turpentine, pour it in the gauze piece and put it over the wound area. So all the wounds, will stick onto the gauze piece. And, if something is there, remove manually, right? That kidney tray, whatever you have lukewarm water and put turpentine oil. So if you put the gauze pieces, it will float. Okay, it will die. So these are all about physical management. Have you all clear with the physical management? Any doubts? I'm stopping here with the physical issues. Any doubts? And how to manage pain, maladar, bleeding, any other doubts? Then we will move on to the psychological issues. No doubt, madam. Thank you, Anita. Okay, let me continue. Apart from all these physical issues, the patient also will have a lot of psychological issues. We talked about a breast wound. We talked about a buccal mucosa wound. What is the biggest problem in the wound? Tell me, altered body image. The patient with the buccal mucosa, you can't go with that face anywhere. Okay, you will hide with the scar. There will be a wound. There will be, affect the whole body image is affected. And, they will go into depression. There will be, lot of anxiety whenever you go and do the dressing. There will be a lot of anxiety. They'll think that the wound is there as it is. It's not healing. What should I do? There will be a fear of death. There will be isolation. The patient feels shame. There will be, their sexual life is affected. Nobody is asking, right, how your sexual life, everything will affect. The patient will have lot of psychosocial issues. It's very difficult. Always we think that we will take a dressing tray, go next to the patient, do the dressing. It is not like that. So it is like how to handle, right? That's what I always tell my nurses. When you go for dressing, talk to patient. Okay, talk to patient how it is, how they are feeling. Okay, so it will give a lot of idea about the wound. Okay, and you also need to educate the family members. It's not about dressing. They have to be involved after dressing, ask their opinion, involve in the family decisions in all those things. So that is very important thing. The social problems, the family isolation, the family, especially if the elders are having these kind of. I have seen one patient in my home care visit when I went for wound visit. I saw the patient with the wound. They put the patient on the cow shed. The family is there. This patient was in cow shed. I told them, why are you leaving the patient? A lot of mosquitoes smell and already fungated wound. These mosquitoes will go and sit. They said, no, 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 children are there. Okay, the family will isolate and they can't travel, they can't go. And we asked the patient to shift to hospice. Then the patient got admitted here. We started to do the dressing and the social isolation, the social stigma, right? They will not, because of malodor, they think that this wound is very big, the wound is very ulcerated, it looks like one cauliflower, right? That they think about it will be very contagious. They will not, involve, and it gives lot of effect on the family members. They will not involve with all these activities. They don't know how to do dressing, and they will trouble the patient. They trouble the family, and they don't bring the patient only for a dressing to hospital. A lot of issues will occur. And as I said, there will be a lot of effect between the couples. If they are couple, their marital life will be affected. There are a lot of, family will get breakdown. So it's not only a psychological issue, there is a lot of social issues also we need to handle. Wound is not only wound. There is a wound, I will go and do the dressing, apply a gauze and come back. No, there are a lot of issues in the wound. Okay, apart from that, the patient will not tell why I got this buccal mucosa. I was, keeping fasting for every Thursday. I was a good wife, good daughter, good mother. Why I got it? I was a vegetarian. I never had, any bad habits. I never had even non-vegetarian. Why did I get? So many questions. Then they will stop going to temple. They will stop doing puja and all those things. They think that why it is happening. Is it a punishment from the God? And they think about their death. Okay, my death is nearing, that's why these are all things happening. They will have a lot of dilemmas, like, what did I do? Is somebody cursed? Or they have a lot of guilty feeling, did I do any wrong, any sin? Or my relatives cursed me, or because I did that one, that's why it's happened to me like this. So many dilemmas will be there. So all these things are very important to address when the patient come with the wound. So the wound is not only wound. The wound is about how the patient is with the wound. That is matter here. End of all these things. Okay, all these things we will be doing when the patients are with us. Imagine if the patient is getting discharged. The patient is not in our hand. We have to try. Look at this picture. Do you think these people are all professional caregivers? Do you think can able to do whatever I taught metronidazole and about the systemic analgesics and local application? Do you think they can able to do? They don't know anything. If you tell them gospice, they don't know. If you tell them dressing pad, gumji pad, they don't know. So our responsibility is empower the caregiver. You don't know what is their knowledge. You don't know what is their attitude. Attitude, I told you, the very first slide I told, I love my husband, I love my mother, but I don't know how to do. I feel nauseated. I can't eat my food. How will I manage? Okay, there are different kind of age group. And you see in this picture, everybody is female. Can you see any male? So automatically the caregiving part, it's fall on the females, right? There are very few males we can count, or there won't be much also. So you could see when I was empowering caregiver, you see how many people I'm talking about dressing. How are you doing? How do you manage? So this is all about, you need to check their knowledge, attitude. How do they practice? Once you teach and send, it will not help. So what you have to do, once the discharge is planned, you have to tell the family caregiver, right? Discharge is planned. So what you have to do, you 1 week before, you take the caregiver along with you and show the dressings. Once you show, they will understand, and then they have to follow everything. Okay. The practical demonstrations would be very good, and you need to follow up them, how they are doing. You should ensure the home care team, either you are going or your team is going, ensure them how they are doing in the home care setup and what is your goals of care, right? Till last month, they'll think you might tell do 2 times addressing, they will do 2 days once. Okay, so many things. Okay, and it will suffer, it will make the patient to suffer more and more. That is what I have been telling. The symptoms has to be addressed properly. So you have to ensure the quality of care and the symptoms, everything. And the dressing is very costly. It's not that easy to do. Okay, whether you use normal saline or gauze pads, dressing pad, it's very, very expensive. And if the patient is going to live for next 4 months, next 5 months with the wound dressing, it would be highly complicated for the patient. So what you have to do, you have to talk to family members. How are you going to plan? And you can educate them how to prepare normal saline, right? In the home care settings, they can take 1 liter of water, 2 tablespoons, not a teaspoon, how you put sugars, no, for a coffee. 2 tablespoons of salt, boil nicely. They can pour once it is cooled, and you can pour it in the airtight jar or something, water bottle, that can be used as a normal saline for 24 hours. Either oral care or dressing or any irrigation, they can use. Okay. And even the dressing materials also, see, it's the gauze pieces, 4 cotton balls, 4 gauze pieces in a pack. It's expensive, 40 rupees, 45 rupees. So what you can tell them, so they can have, every family, there will be a soft cotton cloth that should be washed and dried nicely in the sunlight. It will be a biggest problem in Bengaluru. Okay, it's every time rain, cold and everything. Other places are very good, the places with good sunlight, they can dry nicely. Otherwise, they have to iron it nicely, steam it. Then that has to be cut into small pieces like a gauze piece, fold nicely, put it in one tiffin box and steam it in the pressure cooker or idli maker, whatever is there, or your momo maker, whatever is there, steam it, just steam it. Don't put it CT for 30 minutes. And that is a sterile cloths, gauze pieces that you can use. So economically, when you design the dressing, it's not about the wound, the dressing material. Look at the patient pocket also, how much they can afford. You should be a pocket friendly nurse. Okay. Then you design the dressing, look at the wound bed, the contact layer, whatever dressing you are doing, it should not hurt the patient, right? And how you are occupying the space. Once you do the dressing, the hair should not enter. Clean. And if there is a deep wound or tunnels, you have to pack it nicely. When you pack it, count the gauze pieces. You have to remove the, take out the same numbers and maintain the moisture in the wound. That is why we use the Vaseline metronidazole dressing. Okay, and protect the wound and hold the wound properly with the gauze pieces. And and how to take the bath with the wound dressing. All these things you have to teach and cover with the plastic cover and all those things. Pain management, please, without doing pain management, never touch the patient. Patient will cry with the pain. So do the pain management and address why the patient is having wound or the patient is having any other issues. Okay, when you design the wound, it is not only, as I said, only wound, the psychosocial issues. Go start, how are you feeling? Is the wound is paining or any smell is coming? Talk to the patient, ask about other family visited or whatever it may be. You have to do properly. This is your bottom line. Clean the wound properly, cover the wound, moisture the wound. Waterproof surrounding is very, very important because you can't keep the wound open. Flies will be there. If it is go and sit, it will lay the egg. Maggots will form. Okay, take care of the tissues, protect the wound. So these points are very important. Okay, so you can do the best wound dressing with this. So your take home messages. Patient comfort is very important. Till last moment, comfort and dignity is very important, though the wound is not healing. Okay. Don't worry about whether the wound is healing or not, but provide comfort to the patient. Individualized case-based symptom, where some patient will have pain, some patient will have malorder, some patient will have psychosocial issue. Okay. So how the patient is suffering, based on that your care plan should be. Everything will not happen in one hand. Okay. Even in the wound, the nurses will play a major role. But something in case of heavy bleeding, you need to have a physician support. In case if the patient is having, high distress, you need to have a counselor. Always multidisciplinary team. Inform, always talk to your team. Provide, multidisciplinary support to the patient. And whatever you do, communicate to the patient and family, because patient will have thousands of doubts. You need to communicate with them very effectively, which is very important. So these are all your take-home messages. Select dressing, provide comfort to the patient, never allow the patient to suffer, always work as a team, empower and communicate to the family members. This is what my key message to you. Whenever you do see the wound, don't see the hole in the patient. See the patient as a whole. Okay, you have to provide, complete patient care, holistic care to the patient. Okay, whatever the assessment, PQRST, OPQRST, or wound assessment tool, or the management, or psychosocial, everything as a package you have to provide to the patient. That is very important in palliative care. Palliative care is not only that the patient will come, take a ointment, apply in the wounds, say bye-bye. Okay, you have to provide holistic. You have to see them as a whole patient. Examine the whole patient. That is your take-home message for today's session. Thank you very much. Look at how big wound, how nicely nurses are handling. Thank you so much. Any doubts? I have enough time to clarify your doubts. Please come up with your doubts. I can help you answering your doubts. Yes, you can also, if people are in duty, put it in the chat box. Thank you. Yeah. Then, any doubts?
Participants, please post your doubts in the chat box, or you can unmute yourself instead of thank you.
Is the session was useful? Did you learn any new skills, techniques?
Yes, ma'am.
Very good. Anita, any doubts?
No, ma'am.
No, very good. Now you won't be having any doubts, but when you really get a patient and if you take a gauze piece and if you find maggots, that time you will check your notebook and slides or what to do. It's not a problem. Whenever you find any doubts, you just write it to your Pallium team. My mail ID is there. Whenever they write, I'll get back to them immediately. Both the slides, I'll share it to you, Monday and today's slides together. Okay.
Okay.
You can share with the participants. Always use sniff ladder. Okay. Never forget, which is very useful. We have seen lot of, change in the patient. Especially foul smell with the fungating wound, more than pain, it's so terrible. We could see a lot of, drastic change in the patient condition. So use all these things. Good. So if there is no doubt, nothing is from my end.
Okay, ma'am.
Thank you so much.
Thank you, ma'am. Thank you so much for the wonderful 2 seconds for taking us through. I hope the nurses get some their doubts clear. If you have any doubts in the further, I can forward it to ma'am. We will get a reply and I will forward it to you. Thank you so much, ma'am, for this session. Thank you all.
Thanks, team Pallium, for the opportunity. Thank you. Bye.